Okay, hello, and welcome to today's video where we will be discussing the diabetic retinopathy. Now, diabetes as a disease is very common, and in our daily lives, we see people and siblings who have this disease. So, you've probably encountered someone with diabetes. So does the diabetes affect vision? Yes. You've probably heard of people who have cataract, and one of the predisposing factors are the diabetes. But can it also cause other pathologies such as diabetic retinopathy? So today we'll be exploring a very important topic, which is the diabetic retinopathy. So we'll be explaining the pathophysiology first of the diabetic retinopathy, and you may wonder, why do we start off with the pathophysiology and not the clinical picture? Well, because the pathophysiology, will help us understand the clinical picture, the signs, and the symptoms that the patient is presenting with. We'll talk about the incidence rate and predisposing factors, followed by the treatment. So let's get started by the pathophysiology. So before we go into any of these details that you see in front of you, we have to mention two important things. So the diabetes affects the microvasculature. So these are the capillaries, okay? So we're talking about the capillaries right now. And it causes two main pathologies. The first one is microvascular leakage, as you can see. And the second one is microvascular occlusion. So you may go over them quickly and not understand what's actually happening, like why does the diabetes lead to leakage, and why does it affect the microvascular part, which are the capillaries. So let's take a step back and go see the histology that we have. So the retina is a very dry place, guys, so you have to keep that in mind. So we can't have any fluid going there, because any fluid would affect the light. Now, after all, the retina is a layer which is responsible for taking light from outside and converting it into signals, sending it to the brain and understand the image. So imagine that you have some water maybe or anything, it would distort the image that we have. Okay, so how do we keep the retina dry? Okay, so we have capillaries, and capillaries, some areas in the body, they could leak fluids outside, and you've heard of many areas that do that. For example, the kidney and the glomeruli, they leak fluids, okay? But you've probably heard of the blood-brain barrier. It's an area where no fluids could easily enter, right? Over here in the retina, we have what's called as the blood-retinal barrier. So if we zoom in over here, we could see the tight junctions between the endothelium cells. So this is a picture showing the capillary, okay? And we have tight junctions present over here. Now, this tight junction role is to prevent leakage of any fluids, okay? And it's supported by structures known as pericytes. So let's take a look up here. So we have a vessel, okay, and this vessel is surrounded by a cell which have, like, we could say claws maybe. It has extensions coming outside of it, okay, and it surrounds the capillary, and its function is to keep this function is to maintain the integrity of the blood vessel and regulate the permeability. So we don't want fluids leaking from outside, and it maintains the integrity of the blood vessels, okay. So let's just say that some process occurs that leads to loss of these pericytes. We would lose the integrity of the vessel, so it's no longer well defined in shape and circular, as you can see in the cut section. No, it could lead to aneurysms, okay? And this tight junction will be harder to maintain because the pericytes are like creeping around it and keeping it in place. So losing them would mean that these tight junctions would be disrupted. So this means that the capillary has increased permeability and the fluids will leak outside, okay? So now that we've discussed that, let's see what happens. So in diabetic patients, especially those who are uncontrolled, we have hyperglycemia over here in the blood, okay? Now, over time, the glucose, of course, enter any cell, okay? Not any cell, but the glucose enters some of the cells, the endothelial cells that we have over here, and it leads to a pathway which leads to the formation of a structure known as sorbitol, okay? Now this sorbitol is not the same as glucose, and you may ask why, because the sorbitol as a molecule itself, it's larger than glucose. This is the first point, and it's not easily metabolized as glucose is. Now this process doesn't only occur in the endothelial cells of the capillary, it also occurs in the pericytes which surround it. So now we have a sorbitol inside the cell. This sorbitol is not exiting. So what does that do? It increases the osmotic stress inside the cell. So water begins to enter, and this leads to swelling and disruption of the cell. So if we are talking about the pericytes, their disruption would lead to increase in the permeability, disruption of the cell. So this would lead to microaneurysms. So what happens in this picture over here? So over here we have a disrupted capillary, we have increased permeability, and we have no pericytes because they ruptured. And what does this do? First of all, it leads to leakage of fluids which were present inside, and this includes basically the plasma, okay? And this later on will lead to macular edema, but we'll talk about it in a second. And what does the blood contain? It has plasma, so it has albumin, it has fibrin or fibrinogen, it has lipoproteins, and it has cholesterol, okay? So these go outside. Some of them are dried up, okay? The water is reabsorbed and it leaves like a spot over here. Now we'll talk about it. This is known as the hard exudate. Okay, so some capillaries can withstand the aneurysm, okay? But some, however, the capillaries as a structure, they are very fragile, okay? So they could rupture and lead to small spots of hemorrhage that we will see in the retina. Okay, so so this is the pathophysiology of the leakage part. Okay, now let's go on to the microvascular occlusion. Now I have to remind you, we're living our day to day, and we're grateful that a blood clot doesn't occur in our system as we go on with our day. So how does that happen? We have clotting factors in our blood, and we have anticoagulant factors or anti-clotting factors, which prevent the blood clot to occur. Now, the anti-clotting factor could include antiplatelet factors and anticoagulant factors. Okay, so we don't want platelets to aggregate, and these platelets would lead to a blood clot later on. So what's responsible for this part? Well, the endothelium has a very big role in this part. Okay, it secretes nitric oxide, which is a vasodilator, and also prevents the platelet aggregation, and prostacyclins, which prevent the platelet aggregation. Okay, now by preventing platelet aggregation, we prevent a blood clot to occur. Okay, and if a blood clot begins to occur, we have substance such as the strombomodulin. I know the handwriting isn't the best, but it's called strombomodulin, and this is an anticoagulant secreted by the endothelium. Okay, so we have a disrupted endothelium. If we go back, this endothelium is disrupted. Some of the cells are swollen, some of them are ruptured. So there's a deficiency in these substances that are secreted. So there's a higher risk of formation of small clots or aggregations in the capillary level. So this leads to its occlusion. So if we move on and I tell you retinal ischemia, so it makes sense because there is an occluded blood vessel, and the blood vessel carries oxygen, and there's no longer oxygen going to this part, so it would lead to an ischemia, definitely. Okay, let's move on. So what's gonna happen? So what's next? Now we have leakage, we have occlusion. So the retina has photoreceptors. Now if you don't know, the photoreceptors are one of the most demanding cells in the body in terms of metabolism. So these cells require a high amount of oxygen reaching them. So what will the body notice, or the retina? So there's leakage and there's occlusion, and there's an underlying pathology which affects the retina. So not enough oxygen is arriving, basically. So what does the endothelium do? It releases the vascular endothelium growth factor, also known as the VEGF. Okay. Now, what does the release of this substance do? we need to form new capillaries, and the new capillaries that will form will provide us with better oxygen, or that's what we at least thought. Now the problem that we have is that these new vessels are extremely fragile, okay? And these fragile vessels could easily rupture, they could easily leak, so this worsens the pathology. So this is why we have stages in the diabetes. So what stages do we have? Okay, we have two stages before the release of the VEGF, which is responsible for formation of new blood vessels. So we will call them the non-proliferative diabetic retinopathy. Okay, we could consider this mild. This is stage 1, also known as the background diabetic retinopathy. And we have the severe non-proliferative diabetic retinopathy. Now 15% to 50% of the people who reach this stage will reach to the proliferative diabetic retinopathy. And finally, we have the advanced diabetic eye, in which complications begin to occur. Okay, so right now, if me and you were thinking of a treatment, okay, we could think of a treatment known as the anti-VEGF. Now, this is the main problem that we have. Not the main problem, of course, we have to control the blood sugar level. Okay, this is very important. And also hypertension has an important association, which we will talk about in a second. And the anti-VEGF. So these are new drugs that have been produced, and their main role is to stop this VEGF, stop the capillary formation, and calm down the process that's happening and prevent the progression. So keep that in mind, and let's get started with the non-proliferative diabetic retinopathy. Okay, so I'm gonna pull out my pen here, give me a second. Okay. What will happen? We said that we have leakage, loss of parasites, and this could lead to hemorrhage, right? So these are the processes, like nothing is new. We have microaneurysm, we have hemorrhage, we have hard exudates, which I will explain in a second, and possible macular edema. Let's get started with microaneurysm. So we have very small spots. Let's go over them, okay? Now these small spots are microaneurysms, okay? This is an increase in the size of the capillary, and it appears as a very small spot, okay? And we have hemorrhages, so some of them may rupture. It could lead to a dot, which is very small. Now, I will go over this and you will say, hey, wait, this is very similar to the microaneurysm. And I'll tell you that, yes, this is true. And we differentiate between them by using a fundus fluorescein angiography, which is known as the FFA. But I will leave this detail outside of the video, but yes, you can differentiate between them. But we're just taking a look at this picture, okay? Now, this is the dot hemorrhage, which I went through over here. Okay, so let's see what's a blot hemorrhage. Now, this is a larger patch. This is known as the blot hemorrhage, okay? Blot. Now, my handwriting is not the best, and I know that. So I'm working on it, I promise. Now, what else do we have? So these increased permeability, which says there will be leaks of lipoproteins, such as cholesterol, albumin, fibrinogen, and stuff like that. And the water is sucked, so it causes like a patch which is yellowish due to the fat content inside of it. So look over here, this is known as the hard exudates. Okay, that's enough. And yeah, so let's recall our picture. This is the optic disc that I've just covered. Okay, wait, give me a second, I'll clear this the image. This is the optic disc, okay? And this is the hard exudates. Now, keep in mind, I mentioned in the last video that the macula is very important for the visual acuity. Now, what do we have? We have a hard exudate spot inside of the macula. Now, this is the part responsible for forming the visual acuity. Now, imagine having this large piece of exudate in front of our macula. Now, this would of course affect the visual acuity of the patient. Now, he will start complaining of, for example, blurring of vision, okay, because of these spots. Maybe even some small hemorrhages, okay, flow inside of the vitreous, which is in front of the retina, yeah. So he will see some floaters, maybe some small dark spots. So yeah, keep that in mind. Finally, we have the macular edema. Now, we also mentioned that so just keep in mind, just because this picture has all of these stuff doesn't mean that the patient has to present with all of them, okay? So we have macular edema. So for example, we said that increased permeability lead to fluid exudation. Now these fluid exudates will cause macular edema. Now there is water in front of the macula, and we mentioned that it's very important to keep the retina dry. So here's an example of diabetic maculopathy. Now the diabetic maculopathy, it includes two stuff. We have the macular edema, which we have discussed, and the macular ischemia. Now the process could take, so just keep in mind, we said we have leakage, we said we have occlusion. Both of them could occur. One could occur before the other. Now this is the body, it has no defined rules, okay? So if there's occlusion that occurs, and this would lead to ischemia, okay? So there is no blood going to the macula. Now, you know, if there's an ischemia that happens and this tissue doesn't have enough oxygen, it will lead to the death of this tissue. Okay, so the macular ischemia has no treatment. This patient complains of drop of his vision, okay? And if you have macular edema, this could be treated, okay? And they can differentiate between it, of course, yes, they can. And macular edema treatment is by using the anti-VEGF, which we have described. Because the problem, as you can see, is that we have a leaking blood vessel, and these blood vessels are formed, they are fragile, they have increased permeability. We give the anti-VEGF treatment and it treats the macular edema. And macular edema is one of the most common complications of the diabetes, okay? In the diabetic retinopathy, of course. Now, let's move on. We have moderate to severe non-proliferative diabetic retinopathy. Now, take care. Till this moment, there is no proliferation, okay? The VEGF secretion, of course, it's happening, but it's still not severe enough, okay? The retina is ischemic, okay? And it also has many other problems going around. So what do we have over here? Let's go quickly. This is a blood hemorrhage, which I've just circled, okay? And what do we have over here? We have spots, okay? Now, these spots are whitish, and these are not hard exudates, which I will show you in a second. So what are these? These are known as the cotton wool spots. We said the retina is ischemic, right? So this is infarction in the nerve fiber layer of the retina. So they appear as a white spots. This is the cotton wool spots. The second thing that we have is known as IRMA, which is intraretinal microvascular abnormality. So we will start to see shunts, as you can see over here. Very small, very delicate. I'll make a small arrow, okay? Between the arterioles and the venules, we begin to see anastomosis and shunts opening because the retina is ischemic and they begin to open shunts between them. So this is very important because this means that the next step is that new vessels will start to form, okay? And we have segmental dilation. So if I zoom in down here, this part over here, as you can see, it's like closed and then opened, closed and then opened. I know it's very small, okay? But this is dilation because there is loss of the regulation and the vein loses its normal tone because the parasites are affected, okay? Some areas, some capillaries have occlusion. There is an underlying pathology and the vein cannot maintain its tone anymore, okay? So this leads to segmental dilation of the retinal vein. Now let's quickly compare between them. Okay, so these over here on the right side, these are known as the cotton wool spots and these are known as the hard exudates. Okay, these are the hard exudates. And also keep in mind, they were also called soft exudates previously, but they are not exudates, okay? This is the wrong naming given to it, and these are known as the cotton wool spots now. And they are not caused by any exudates. As I've said, they are caused by infarction, okay? And what else do we have? We have the intraretinal microvasculature abnormalities, and yeah. So let's move on to the proliferative diabetic retinopathy. Okay, so we have new vessels that will begin to form, and we said by the VEGF. So we classify them into 2 or even 3, okay? We have new vascularization, which means new vessel formation at the optic disc, okay? It's known as the MVD, and we have new vascularization elsewhere, okay? Also known as MVE. And we have new vascularization which occur at the iris, okay, of the eye. And we'll talk about that in a second because it's an important complication. Okay, over here, let's start at the left side. Now, look at the amount of abnormal vessels that are forming, and they are a lot. Okay, a lot of vessels are forming and it's so irregular. As you can see, it's the MVD. What's the problem of the new vessels? They leak, they are very fragile, they could rupture, and a large amount of rupture would lead to hemorrhage. Now, what's the problem if hemorrhage occurs? Okay, this hemorrhage will float in the vitreous. Now, the vitreous is a gel-like substance in front of the retina. Now, it would flow in front of it and it would cause floaters to this patient, okay? And MVDs are more likely to cause vitreous hemorrhage than the new vascularization elsewhere. So look at this picture over here. The amount of new vessel formation is immense. Lots of vessels are being formed and it's so irregular. Like, this will not solve our problem because they don't deliver enough oxygen and it doesn't fix the underlying pathology, the ischemia that's in the retina. Okay, and we have new vascularization at the iris. Now, this new vascularization at the iris could lead to glaucoma, and we'll talk about it in a second, also known as the new vascular glaucoma. Okay. Okay, so this is the advanced diabetic eye. We have 3 main stuff we will talk about. First one is the vitreous hemorrhage. Second one is tractional retinal detachment. And you'll say to yourself, like, what's bringing retinal detachment here, which I will explain. We have vitreous hemorrhage. So look at this picture in the retina. What do we have? We have, let's just say, a boat-shaped, hemorrhage. And this is caused by vitreous hemorrhage. There is rupture in the capillaries, okay, and this is vitreous hemorrhage. Now, it's also known as pre-retinal hemorrhage, so it's not behind the retina. So let me just simplify it to you. We have the vitreous, followed by the retina, followed by the choroid, okay? So this is hemorrhage between the vitreous and the retina. So we don't see any vessel. Now, look over here, this part, like the vessel begin to disappear because we can see it. This is caused by the vitreous itself, okay? Now, if the bleeding was from the choroid, we will be able to see the vessels because it's behind the retina, okay? So this is the vitreous hemorrhage. We have the tractional retinal detachment. So how does traction means there's a force pulling until it detaches. So what is the origin of this force? So we said that there is leakage and it contains many substances which we've explained. And one of these substances is fibrinogen. Okay, now this fibrinogen over time could turn to fibrin, and the fibrin will lead to a contractile fibrous tissue which is inside the vitreous and attached to the retina. Now, over time, it keeps on pulling until it detaches the retinal pigmented epithelium from the neurosensory retina. Now, keep in mind, retinal detachment is not detachment of the whole retina from the choroid. No, the retinal pigmented epithelium is detached from the rest of the retina, okay? And finally, we have neovascular glaucoma. Now, you'll say, like, what is glaucoma doing over here? Now, look at this picture. We have the iris, and look, it's not like the normal iris that you see. This iris has lots of vessels formed. Look at the arrows that I've drawn. Now, these blood vessels occlude the angle, okay? We have an angle between the iris and the cornea. Now, the formation of new blood vessels will occlude the angle, and the occlusion of the angle will lead to a problem in draining the aqueous humor, okay? Now, this would lead to a rise in the intraocular pressure and start to form problems in the optic disc, okay? So these are the 3 main complications that we have. This is the vitreous hemorrhage, another picture, and I want you to notice that the blood vessels here, look, this part, like, it should continue like that, you know, and over here continue like that. No, this part is not seen because there's a hemorrhage in front of it. Okay, so now we'll talk about the symptoms, and it will be so much easier once we understand the pathophysiology. So what will this patient complain about? He will have blurring of vision, which makes a lot of sense because we have the macular edema which occur and even macular ischemia, and this of course affects the vision. This part is responsible for the visual acuity, and also the blurring of vision could be related to the blood sugar level. Okay, now this is related to the lens of the eye. Now we have the lens of the eye. Now there's a process that occurs where glucose accumulates inside the lens, okay, and it's turned into sorbitol, and this sorbitol sucks in water. Okay, now the lens would swell. Now it will be swollen like that. Okay, now this leads to a process known as index myopia. So the patient becomes myopic with increase in the blood sugar level. So I don't know if this part is related to the retina, but it's also related to the lens. Okay, there could be floaters due to small hemorrhage in the vitreous. Okay, he will see dark spots, also known as the floaters. Okay, there could be darkening in the visual field. And why will that occur? Because the retinal detachment occurs or the retinal ischemia. Now, if the macula doesn't have a blood supply, now this part will die in the macula, and this part will no longer be able to see. So it leads to dark areas in the retina, or even detachment, okay? But keep in mind, these processes are often gradual, okay? Except the dark area, I'm sorry. Now, the first 2 points are usually gradual, right? Because the macular edema, it's not like the patient sleeps and wakes up the next day and he has like blurring of vision. No, it takes time. It's a process that's ongoing for many years, okay? Now, if the patient complains of sudden loss, okay, of vision, now this is an emergency. Now, the vision shouldn't drop overnight. This is an indication of vitreous hemorrhage. Now, take a look. Now, the light is trying to enter and there's a large amount of blood inside of here now. This is not normal, okay? So this leads to a sudden drop of vision. Okay, and this is an emergency. Of course, this is an emergency. Okay, and we have 2 main investigations that we require. We require the OCT to see the macular edema and the fundus fluorescein angiography to see the vessels, okay? And I will just enumerate them as names. I will not go into details. Now we'll talk about the incidence. I know this slide is like a big slide, but I'll go over it quickly. Okay, so incidence and predisposing factor. Let's start with systemic association, okay? The last point down here. Now, if the disease is associated with diabetes or with obesity, now obesity, of course, increases the diabetes and it decreases the sensitivity to insulin. Now, it worsens the condition, of course, and pregnancy increases the risk of developing diabetic retinopathy because pregnancy is also associated with gestational pregnancy. Okay, and finally, systemic hypertension leads to blinding complication. Now, imagine that we have a fragile vessel already, and this patient has a normal blood vessel, so the exudation will be, okay, there's some exudation, but not a lot of exudation. Now, imagine if this is associated with hypertension. There will be more rupture, there will be more ischemia, and there will be more issues that will occur. So association with systemic hypertension is a blinding complication, and you must manage both the blood pressure and the blood sugar of the patient. Now, if this patient is type 1 or type 2, does it matter? Yes, it does matter. So if the patient has type 1, okay, 20% of the patient develop it after 5 years of the onset of type 1, and 80% of the patient develop it after 15 years of onset. This means that there will be start of some complications of the diabetic retinopathy. Okay, if there is type 2, at the time of diagnosis, now, like you don't know the exact onset of the time of type 2, unlike type 1. So there is probably a significant retinopathy at the time of diagnosis. Okay, because the blood sugar was not previously controlled. Okay, but however, type 2 tends to be less severe than type 1. So type 1 is worse than type 2. Now, does glycemic control play a role? Yes, of course it plays a role. So if you have a good blood sugar, this would lead to less glucose going into the cell and converting into sorbitol, and this process would dramatically decrease, okay? So it prolongs the time of till the onset of any complication, okay? And it reduces progression. Now, let's talk about the treatment. Now, we've discussed the anti-VEGF, okay? And there is two main things that you have to focus about, the blood sugar and the blood pressure, okay? We will have to regulate them, and there's a very important point. We have to do regular checkups. Now, you will ask why. So let's go back 1 second, okay? We're about to finish this video, don't worry. Over here, let's take a look at this picture, okay? Give me a second. Okay. We have this picture right now, okay? We've discussed this slide before. Now, outside of the macula itself, if there is no problem in the, okay, so outside of the macula itself, if there is a problem here, okay, a small spot of hemorrhage, this is a blood hemorrhage, a small spot of hemorrhage, will this affect the vision? Not dramatically, because our main focus is the macula. We want to avoid any problems in the macula, okay? And by the way, in the treatment, we'll talk about a treatment line where we will give up the peripheral retina and give up the peripheral vision just to save the macula as the central vision and responsible for the visual acuity. So these small spots over here, these are signs, and it doesn't mean that it has to be symptomatic to the patient, okay? So you could see them by your eye, and it doesn't mean that the patient will be complaining of changes in vision. So regular checkups are very important, because when we see these spots and we see that they are outside of the macula, the patient may not complain of anything, okay? So we have to follow up this patient. And now let's move on to the treatment. So anti-VEGF is the first line of treatment that we have, okay? So we give repeated treatment of intravitreal anti-VEGF, okay? It reduces the macular edema, okay? And it reduces the new vessel formation, also known as the new vascularization, okay? However, its disadvantage is that it has a high cost to the patient and repeated injections are required. And keep in mind, these are not intravenous, these are intravitreal injections, okay? So the next line of treatment is the pan-retinal photocoagulation. We want to use a laser, go inside the eye and start hitting the periphery of the retina with laser. So what are we doing? We are basically killing the periphery of the retina. So what will we gain? So this retina has a specific surface area, okay? And this surface area requires a specific amount of oxygen. Now, the underlying pathology, the occlusion, the ischemia, this leads to a decrease in oxygen supply to the retina, so the VEGF is secreted, okay? Now, if we kill the periphery of the retina, okay, so this leaves a small amount, so this leaves a smaller part of the retina. This means less oxygen demand. So now that we have less oxygen demand, we can meet this demand and there will be less VEGF secreted because the ischemia would decrease, right? So this is what we do. We use laser to hit the periphery of the retina. And keep in mind, when we hit the periphery of the retina, yes, this could lead to loss of peripheral vision, but we want to preserve the macula, okay? So another disadvantage of the anti-VEGF is that it causes less destruction to the retina. Now, we doesn't shoot any part, we just injected the anti-VEGF, okay? And finally, we have the pars plana vitrectomy. So what is the pars plana? Now, the ciliary body has two parts, okay? One called the pars plicatum, okay? And one called the pars plana, okay? So we enter from the pars plana and we remove the vitreous. Okay, this is what's called the pars plana vitrectomy. And in what cases do we do that? In vitreous hemorrhage and tractional retinal detachment. Okay. Structural retinal detachment, we remove the fibrous contractile tissue that's pulling, okay, by removing the vitreous, so we solve the retinal detachment issue. Or if we have vitreous hemorrhage. Now hemorrhage, now keep in mind this vitreous doesn't renew as easily as the aqueous, okay? Small spots of hemorrhage could resolve on their own, but large hemorrhage, as the slides you've seen, now these don't go alone, on their own, and they require removal of the vitreous in order to solve the pathology that we have, okay? So that's it. Thank you for watching. I hope this video helped you out. And we've went through a very important topic, and I hope I've made it simpler to you. Thank you for watching, and I'll see you in the next video.